morning, everybody. We'll get started. Today, I have the pleasure of introducing Dr. Nabil Tariq. I was telling him he's probably one of the few non-cardiac surgeons who's probably addressing us, which means some interest in the topic. But Dr. Tariq is an assistant professor of surgery at our institution. He's been here for the last 4 or 5 years, I think, right around the time when I started here. But he graduated from medical school in Aga Khan University in Pakistan, and then did his general surgery in Michigan in William Beaumont, followed by a fellowship in surgical critical care in University of Pennsylvania, and then did his fellowship in minimally invasive and bariatric surgery at Cleveland Clinic, and joined us since then, has led a lot of efforts in bariatric interventions, and has actually played a key integral role in, he and his partner Vadim Sherman have played an integral role in some of our high-risk patients for heart failure, LVADs, and worked with our surgeons in actually making these patients lose a significant amount of weight and qualify them for transplant. So we're very happy and lucky to have him around, and we hope to hear the latest and greatest in bariatric interventions and their impact on cardiovascular disease. Nabil.
Thanks, Arvind. I'd like to thank Arvind, Jerry, and Barry, and everyone for inviting me to talk to you guys about effects of obesity in general, and how the science is being advanced, specifically with regards to bariatric surgery and its metabolic effects. Hopefully to let you know there's some stuff in the background going on that's beyond just technical plumbing changes that we do in a patient. We're going to talk about a little bit about obesity prevalence, impact on cardiovascular disease, some weight loss surgery intervention, some mechanisms of how they may benefit beyond weight loss, some metabolic effects, any benefits to specifically to cardiovascular disease, and some new sort of less invasive than full bariatric surgery options on the horizon. It's a lot compressed. I'll try to leave some time at the end for discussion as well, and depending on how time goes, we may be skipping some slides. But the body ideal is changing. Plumper people used to be considered quite the attraction, then not so much, and then maybe back again. Because if you can see this, many of you may have seen these slides from the CDC website. It's just obesity prevalence, them defining it a body mass index greater than 30. And the lighter blues are when less than 10 to 15% of the population's obese, and as you see, the darker reds go when 25, 30%. You can see since 1985, as we go to 86, 87, it's like a spread of, now in the 90s, the epicenter seems to be the Midwest and the South there. So now we're getting into the 25, 30% range in the early 2000s. Now it's spreading further. It's like those movies with the pandemic spreads, etc. That lone state of Colorado standing below the 20% to 15% obesity mark has also fallen now. So, this is not a diagram of the blue state versus red state, but more obesity state. And why is this so? I read many papers and scientists, there are these, different geneticists proposed, but in the last 30, 40 years, I don't think our genes changed, or there was that much evolution. Is it really socioeconomic and stressors and imbalance between intake and expenditure? Maybe. This is becoming rapidly increasing problem. And is it an energy balance? Is it as simple as calories in, calories out? I don't know. They say, 3,500 calorie excess can lead to a pound of weight gain, no matter what it comes from, fat, sugar, etc. I don't know if any of you have seen a documentary on Netflix called Fed Up. I highly recommend it if you're at all interested in obesity, etc. It's quite interesting, but maybe not all energy is the same. Who gained weight over Thanksgiving weekend? And sometimes, just on my scale, I think I changed 4 pounds. I don't think I ate 14,000 calories in excess. So there are complex mechanisms that we don't all fully understand. And it's not as simple as energy in, energy out. It probably I was just at obesity conference a couple of weeks ago at our national meeting, and the timing of when you eat those calories can make a difference, whether you have most of your calories are at night where you then become sedentary or during the day. So there's more to it. A little bit before we actually describe some of the interventions, what does this mean for the heart? I mean, this audience probably knows, although some of the data is conflicting. Is obesity bad for the heart? Yes, likely, but in some ways it may be protective. It is, McDonald's, every picture you Google, you put on obesity, it has McDonald's on it, but McDonald's gets a bad rap. It's not the only issue. What are the mechanisms of obesity-induced atherosclerosis? It's probably fairly complex. Not everyone with obesity gets atherosclerosis, and not everyone with atherosclerosis has obesity. But most of the adipokines or the cytokines released from fat cells are detrimental, although adiponectin is likely protective. It's anti-inflammatory. But multiple factors from endothelial dysfunction to initiation to progression of a lesion and even maybe plaque rupture. What we do think is fat is inflammatory. And I think Dr. Hamilton was here. He may attest to that further at the discussion portion. But what about heart failure? There are various studies. This one was published in New England Journal of Medicine about increase in heart failure risk by 5 to 7% for each point increase in BMI. So if your BMI goes from 30 to 40, you may have a 50% chance in increase of getting heart failure. Same thing with left ventricular hypertrophy. In the Framingham cohort study, strong association between left atrial enlargement and AFib and obesity. The ventricles become stiffer. How does that happen? Probably combination of diastolic dysfunction, maybe some local effects of fat. Is there more pericardial fat there that affects things? Just like we think sometimes maybe more perirenal fat can affect hypertension. So the fat can have local effects and peripheral effects or more systemic effects. Leptin is a hormone most produced by white adipocytes, and it can have multiple effects. We'll talk a little more about hormonal milieu a little later, but increasingly they're being recognized both in terms of inflammation, its effects on cardiac muscle, but from what I've read, it's jury's out there. Is more leptin good? In some cases, protective. Others, it's not. What about metabolic syndrome? Is it all bad? Obesity can be bad. Hyperglycemia, insulin resistance can be bad. Hypertension can be bad. Lipid abnormalities. But what about altogether? This is a cumulative graph from a recently published article in 2015, all-cause death in heart failure patients. So if you have metabolic, the blue line you see here, the worst is if you have no metabolic syndrome, but if you do have diabetes. The best may be if you have metabolic syndrome and no diabetes. So, overall, it may not be good, but compared to which one affects more? Is metabolic syndrome in this case protective? Unclear. And that's why there is, as you all are, I'm sure, familiar with, the obesity paradox. I'm an intensivist too. It's true in critical care. Why do obese patients? Now, again, we're talking about overweight and mildly obese. We're not talking about most of the graphs look like this, where they define between 25 and 30 as overweight. You look at many people with 25 to 30 BMI, they look pretty regular-sized people. So, but most of the graph is lowest in that overweight range, lowest mortality, heart failure patients, critically ill patients. And as you get fairly thin, your risk of death increases. This is just one graph I showed, but there are many like these in multiple population-based studies and in heart failure patients. So should weight loss be the only target? Since some weight seems to be protective, should we target other things? Inflammation, obesity, the metabolic profile of the patient? Maybe it's not just weight loss, because are all BMIs the same? I'm sure most of the Texans come in the morbidly obese BMI range. Also, the distribution. These two patients, one has a lot more visceral fat, the other has less visceral fat, more peripheral fat. Their BMI is probably similar and weight's probably similar. But their risk profile may be quite different. So for weight management, so is active weight management going to make a difference? What are the types of weight management we can do? Is lifestyle change the best? If that can be achieved, probably. Actively monitored, how often do you monitor someone? What kind of lifestyle change? What's good? Atkins diet, paleo diet, low protein diet, bariatric surgery option for some, and then some less invasive endoscopic methods. So what about diet and lifestyle change? What about that? If it can be achieved, I think that may be the best way, but the problem is what percentage of patients can achieve that long term? Diet is basically not a lifestyle or not a desirable lifestyle for most people, perpetually dieting, that is. But, what are the effects of it? So this is what's called a look-ahead trial published in New England Journal of Medicine. It was a weight loss through caloric restriction in type 2 diabetes could reduce the risk of cardiovascular events. So the trial was stopped by the NIH around 11 years later for futility. So they had 5,000 overweight patients, obese or overweight with type 2 diabetes. Intensive lifestyle modification with caloric restriction with 175 minutes per week of moderate to intense physical activity and exercise. That's probably good for most people if they can achieve that. Or to basically a diabetes education arm. Good weight loss was achieved, about 8.6% of total body weight, not excess body weight, which is fairly decent, and cardiorespiratory fitness was certainly substantially improved. But only a difference of 0.22% in A1C after 10 years was noted, which is, even if it was statistically significant, it's probably not clinically significant. And there was no difference in the number of cardiovascular event per 100 person years in the two groups at 10 years. So does lifestyle change alone, can it make a difference? Probably to a certain degree. Maybe not all that difference. Here's another study which recently was in the news a lot last year, etc., about the Mediterranean diet, about what's the PREDIMED study or so. So that their hypotheses was that a Mediterranean type diet combined with providing olive oil and nuts to patients significantly reduced risk of cardiovascular disease. So there are around 7,000 overweight or obese elderly individuals, of whom 50% had type 2 diabetes. And with that diet, so these weren't patients that they really encouraged to exercise, or did they exercise more, or that they calorie restricted either. They're automatically, maybe by the Mediterranean diet, some of their calories were a little less, but overall there was no real calorie restriction, just change of diet and olive oil. And compared to the other study with 175 minutes of exercise, etc., in this, there was a 30% reduction in cardiovascular events, whether someone had, depending on their waist to height ratios, meaning someone had visceral obesity or non-visceral obesity. Either way, there was some modest reduction in cardiovascular deaths. So they are doing now I think it's called a PREDIMED Plus study where they'll combine some lifestyle, activity, exercise with diet change to see if those together can make a difference. But these differences you see are quite modest. So what if it's hard for someone to stay on the and get off the track and get onto a healthy lifestyle? They can't just stay. They just can't take that exit. They just keep on going on the highway to obesity, and they can't make it. What are our options? What if someone needs a large change? What if someone wants Starr-Jones or Al Roker effect, where they have a significant large amount of weight loss over a shorter period of time that, in most people, not in everyone, can be sustainable. And also if that's healthy or not. That's also a question. So let me tell you a little about bariatric surgery options as well, some intervention options. A little historically, I showed these two procedures. There are many others, but they're kind of the spectrum of procedures that classically bariatric surgeons would think of or divide into. They talk about purely mostly malabsorptive procedure, meaning eat what you want, but you'll get diarrhea, fatty, smelly stools, vitamin malabsorption. Probably not the healthiest way to go, and cirrhosis. So that's the jejunal bypass. That's why it was abandoned decades ago, pretty much. And this one was done as late as the probably early 2000s, mostly after the 90s stopped, but mainly where we kind of staple part of the stomach and put a little band around it too, and kind of mainly make people like throw up if they eat any too much or too fast. But this didn't work too long term either. America is one of the few places where you'll find achalasia patients and gastroparesis patients that are morbidly obese. These are patients that constantly complain of nausea and that they can't eat anything. Yet their BMIs, about a third of them, their BMIs can be in the morbidly obese range, even the gastroparesis patients. Just the richness of the calories and diet available. The other procedure that we commonly do here now, I'll just describe in a little more detail, so you get an idea because some of the mechanism we're going to talk about in a few minutes and their benefit, it's important to understand some basic anatomy of it. So this is the gastric bypass, one of the most commonly performed and been around for 20, 30 years, quite durable. We cut the stomach into a small stomach called a pouch, maybe the size of an egg or so, or a large egg, and bring a loop of intestine up to bypass the main stomach. Results in about 70% of excess weight loss. So if you're 5'6" and you're supposed to be 150 pounds and you're 300 pounds, you have 150 pounds of excess weight. So you'd lose on average around 100, 110 pounds or so. And there's something about this bypass that greatly helps diabetes right away. We're talking people who are on 300 units of insulin. After operation, they just go on a sliding scale, and within a month or two, frequently are completely off insulin. So all of them are done laparoscopically through smaller incisions. We bring a loop of intestine up. This is the stomach. We cut the stomach into a small stomach and stitch or staple the intestine to bypassing the main stomach. We check it with an endoscopy, etc. The rate of weight loss is fairly rapid. Most of it's within the first 12 to 18 months. Would kind of plateau out by year 2, followed by 5-10% weight gain, and then it plateaus out for probably 2/3 of people. But a third do gain weight of varying amounts, and that's the important part. That these are tools to use. These are we can make your stomach pencil thin, but if someone's really determined, and some of them truly are, they will gain weight. Gastric bypass, there's rapid initial weight loss. We think durable long-term weight loss, but to be honest, we don't have great long-term data. There are multiple studies that have 10-year data, but as a large population of hundreds of thousands of bariatric patients, we don't have good 5-10-year follow-up. A portion of the digestive tract is bypassed, so it does reduce absorption of certain nutrients like iron, calcium, vitamin B12, because a lot of those are absorbed in the duodenum. But we do supplement those, and it's rare to develop significant deficiencies if someone follows the prescribed diet and supplementation and follows up with us once a year for checks. The complication rates I'll just discuss along with the sleeve gastrectomy so you can compare and contrast. This is just another picture of the bypass next to the sleeve gastrectomy, and quite another commonly done procedure these days. And so in that, we cut the big baggy portion of the stomach off. In that's completely detached, so it's permanently removed. Just keep in mind we're removing the fundus here that can produce certain hormones like ghrelin, etc., that we think can affect appetite. So we put a sizer alongside the stomach, and we go up alongside it to make it like a banana. So there's rapid initial weight loss with this too, minimal diet restrictions, maybe 10% less weight loss than the bypass, still pretty close, but slightly lower risk. A little newer than the bypass, maybe 7, 8, 9 years out as opposed to 15, 20 years out. So we think it's good at long term, but we can't say that for sure yet. So what about the complication rates? What are these rates? What is that side of the equation? We've seen all the great weight loss and stuff, and you'll see some of the important metabolic effects, etc. So in a nutshell, where does this compare in the spectrum of surgeries? Is it like a little breast lump? Is it like a little groin hernia? No, it is major abdominal surgery. When you take into account wound infection rates of less than 2%, 1.5% in obese, many diabetic patients, which normally have a very high wound infection rates. Bleeding enough to require repeat surgery, again, probably less than 1% or so. DVT-PE, people always worry about morbidly obese patients, BMI 40s, 50s, 60s, having high rate of DVTs. Lot of large databases, including our own, they're usually less than 1.5%. That's comparable to lap chole, colon surgery, any regular common surgeries, the DVT rate. Because I think that's mainly, we're very aggressive in pre-op DVT prophylaxis, pre-op Lovenox, post-op Lovenox. We even do extended prophylaxis, and they're ambulating within hours of surgery. So leak rates, which are with any gastrointestinal surgery from esophagus to anus, are also quite low. With the sleeve, it's less than 1% now, and with the bypass, it's probably in the 1.5% range. And what about mortality when it comes to these surgeries? When cumulatively you take gastric bypass probably around 0.3%, sleeve 0.25%, but lately, as newer data we've seen of some few more recent studies of thousands of patients, they're more closer to 0.1% or so. Which again, elective colon surgery has a mortality of 1% in the US. Not emergency, but elective colon surgery, cumulative in the US. So it's 2 to 3 times mortality-wise safer than elective colon surgery. I won't spend much time about the band. It's kind of on the out in the sense that we don't do it anymore. Many insurances don't cover it. Long-term results have been poor. Principally, you'll see that, as we'll talk about, it doesn't seem to have much metabolic effects. It's just basically choking the top of your stomach. People either throw up or they don't lose enough weight. These are just average OR times it takes. Hospital stays 1 to 2 nights for most bypasses and sleeves. Not the high-risk cardiac ones. Those stay 3 to 4 days sometimes or longer. But so this is just some cumulative data from 55,000 patients. Mortality, hospital mortality, 0.14%. Readmission, close to 5%. Reoperations, 2%. These are just some larger studies that have longer follow-up about mortality reduction. Some of them seem, I think, a little exaggerated, but these last two in the New England Journal of Medicine in the 30-40% range. This we show frequently. There's nothing like a 100-pound weight loss that will take care of your hypertension, metabolic syndrome, hypercholesterolemia, obstructive sleep apnea, type 2 diabetes mellitus, if it can be achieved safely. And it involves a very close. There's an initial informational session that we give to the patients about a free PowerPoint presentation. It's a good 45-minute long or so about explaining some of the stuff we talked about in more layman terms. Initial consultation, a workup that can last 2 to 3 months, several dietitian visits, followed by very close follow-up with us. After a few surgeries, do you have this kind of follow-up? So it's about a comprehensive program. So we know it works in weight loss, but does it work? What else is good about it? Is it just, okay, weight loss, can that be matched by various diets, et cetera, or fads? It's possible. It goes beyond weight loss. As early as 50s and probably as early as early 1900s, people had noticed that post-gastrectomy, one, patient lost weight, but two, their diabetes seemed to improve as well. Is it all, just caloric restriction and nutrient malabsorption, or are there other effects that happen as well? Even in 2007, the American Society of Bariatric Surgery changed its name to American Society of Metabolic and Bariatric Surgery. ASMBS is our national society. Why is that? We believe it works on whether it's appetite, whether it's glucose homeostasis, whether it's metabolic syndrome. All of them work on, we feel there's a complex interplay. There's no one target for appetite, for metabolic syndrome. If it were, I'm sure there'll be billionaires. But there are some of these axes that some of these hormones work on. We call enteroencephalic axis, sort of gut hormones acting on your brain. Enteroinsular axis, gut hormones acting on your pancreas. And adipoinsular axis, or even adipoencephalic axis, so fat cells acting on the brain and the pancreas. How some of these procedures may work, there's a distal bowel hypothesis, meaning nutrient reach the distal ileum much quicker after a gastric bypass type operation, within minutes of ingestion of food. And there are cells in the ileum that called L cells that can release GLP-1. Now, there are, and these have been shown in both clinically to increase as well. So for diabetes, we have currently medications like Byetta, Victoza, that are GLP-1 analogs. So that's what they call the distal bowel hypotheses for how some of these operations metabolically may work in improving glucose homeostasis. But there's beyond that too. There's a proximal bowel hypothesis. So the exclusion of the duodenum from the passage of nutrients. And there are some devices that do that in some operations. So you're not really bypassing much, but you're just excluding the duodenum. And just doing that seems to improve glucose homeostasis as well. There are a series of basic science experiments that I fully don't understand, but I do know that Francisco Rubino is a bariatric surgeon and a quite prominent scientist in our field. And they've done a lot of experiments on Kakizaki rats or obese mouse models, obese diabetic mouse models about just what they call duodenojejunal bypass. So you're not really making the stomach smaller, you're just bringing a loop of intestine to the stomach. So some food goes directly down, bypassing this segment. And then they do various things by excluding the pylorus, not excluding the pylorus, etc. But in a nutshell, the effect is just by doing simple alterations like that, closing the pylorus, letting it open, whether food touches the duodenum or not, can improve glucose homeostasis. And this is further proof, and they've started some of these surgeries in it'll take a while for the US to come, but in South America, etc., called ileal transposition, meaning you just take a 15, 20 centimeter segment of ileum and don't do anything else. You just bring that ileum to more proximally in the bowel. So food touches the ileum sooner. And they get improved, they get some weight loss by decreased appetite and improvement in their glucose homeostasis. Probably from GLP-1 increase. Because even Byetta and Victoza are sometimes prescribed for weight loss as well. Some of them, like the sleeve, can cut off the fundus of the stomach, which we think is one of the sources for a hunger hormone called ghrelin. This alone doesn't affect appetite, but it's a complex interplay. Ghrelin is supposed to have effects on, this is the enteroinsular axis, on insulin secretion as well. So even this has some metabolic effects beyond just making your stomach smaller, we think. There are other hormones in the brain, something called neuropeptide Y. It's supposed to be the dominant central signal for appetite. But we know that that alone may not occur because they've had some randomized trials of just isolated antagonism of neuropeptide Y. And they don't see a difference in weight loss. There's another hormone called peptide YY. And these are all targets that may be targets for pharmaceutical industry to help weight loss. But this is known as the ileal brake. It has a nice name, ileal. And this may be a little reason behind if you might have found yourself to be really hungry sometimes. You think you can eat like 3 plates worth of food, and then you eat half a plate, and then you get disturbed or distracted by your kids or your phone call, or you do something, and then half an hour, 45 minutes passes, and then you're no longer that hungry. You don't think you can eat 3 plates of food anymore if you just give it that break. And some of the idea behind that is that once food reaches the small bowel, that's why people who eat fast, who like in 5 minutes or have voracious appetite, they tend to gain more weight because they don't have enough time for the food. They don't give food enough time to reach the small bowel to give that negative feedback mechanism that, okay, stop. So one of them, the peptide YY, is supposed to be called the ileal brake, where it causes reduction in motility, secretion, appetite suppression by food reaching the ileum first or quicker. This is the entero we call insular axis, gut hormones acting on the pancreas. Gastric inhibitory peptide, are also known as glucose-independent insulinotropic peptide. This goes with the theory of what we call the foregut, when food doesn't touch the duodenum. We call the foregut hypotheses. There are conflicting levels after Roux-en-Y gastric bypass, but this hormone is in the duodenum, and GLP-1 is a little better studied with the pharmaceutical drugs that are out in the market as well. And this can be responsible in improved glucose homeostasis, again from food reaching the ileum quicker. And there's leptin and adiponectin and all this complex interplay between various hormones between the brain, fat cells, pancreas, and the gut. And we haven't even begun to understand this yet. But there may be someone who may figure out a common pathway for a lot of these that could literally be a pill that can lead to significant weight loss. So for the tail end of things, I just wanted to kind of mention a few landmark studies in bariatric surgery, and then talk just briefly about some less invasive weight loss methods that are out on the market in the last 10, 12 minutes here. So these are all 4 studies published in the New England Journal of Medicine in the last decade or so. And I didn't think there were that many Swedish bariatric patients, but they apparently are. And they're good at, because of the nationalized health system, good at long-term follow-up, et cetera. So that's why they can publish usually good long-term data. But 4,000 patients, this is not a randomized control trial. These are matched cohort. Most of them were actually, less were gastric bypass, more were vertical banded gastroplasty, but even those had good effects, so we think the bypass patients should have even better effects. So I'll just get to the meat of it. So if you look at, for example, just does it save lives? We know it does weight loss. We know it improves metabolic profile, but does it really affect things? So if you look at sort of all-cause mortality or specifically cardiovascular mortality, there is reduction, but even as much or more so, and this is repeated in the multiple tests, as we all know the significant effect of obesity on cancer, from especially female-related cancer, but even male, from everything from breast, ovarian, colon, significant associations with obesity. And after cardiovascular decrease in deaths, the next most decrease in deaths from bariatric surgery in most of the studies have been from decreased cancer deaths. These are just mortality curves for controls and patients who have bariatric surgery. So this is the other famous study called the ADAMS study from bypass surgery. This is from Utah. They had around close to 10,000 gastric bypass patients. That's a lot of patients, 10,000 gastric bypass patients. And then they try to match them with around 9,600 similar sex, age, BMI type patients. In this, again, total deaths. So during the first year, there isn't much difference in mortality, which is not to be expected. We're reducing obesity. The effects may show up over the next few years. So around 2.9% mortality versus 4.4% in the control. And these are statistically significant. So again, in the same group, if you look at cardiovascular deaths, so the hazard ratios for all-cause death, at 10 years, 0.63, cardiovascular, half, cancer, 0.38. So it just further goes to the point of to what degree obesity is related to cancer. The next two are actually randomized control trials published from 2012. Correct. So despite that all-cause, so suicide is one thing that is briefly in the first few months. So when we talk about all-cause mortality, et cetera, that includes the initial deaths from bariatric complications and the increase that is in suicide. But there are a lot of major changes in a person's life that occurs with that degree of weight loss. Around 50% of all the bariatric patients we see are on either antidepressants or psychotropic medications, anxiety medications, et cetera. So they have some baseline psychological difficulty. And people have talked about various mechanisms why that is so. Is it such a drastic lifestyle change? Is it problems with their even household and spouse or partner who previously they were dependent on, now they've become more independent, and that creates a problem with the spouse. So there are many reasons they've thought about for that, but there is a slight increase initially in that. So these are in the randomized control. Again, these are smaller studies, 50 patients in each arm, 30 patients, 40 patients, but when you include, look at A1Cs or changes in BMI, et cetera, with intensive medical therapy versus surgery, there's usually no comparison in terms of what works better. So what are some of the other options, endoscopic options? So remember we talked about excluding the duodenum and that affecting your glucose homeostasis. So this is just a 2-foot liner that we just actually, the trial closed early, so there are some problems with this too. So this is not the answer by any means, but it just goes to show deciphering mechanisms. We were one of the multi-center, around 15, 20 institutions in the country which were part of the trial, and we were one of them. So we place a liner in the duodenum. It anchors in the duodenum and is a 2-foot liner. So all the food, 2 feet of intestine we remove all the time in surgery. That doesn't cause any malabsorption. So we're relying thinking this is mostly working. There may be some nausea and appetite suppression, but mostly by what we call that foregut hypothesis, with food not touching the duodenum. only 2 feet. And how does that affect your metabolic profile? So weight loss with these studies, and they're short-term, 12-week, 12-week, 6-month weight losses, they've been modest. These are excess weight losses, 23%, 22%, 19%. We don't consider that very high degree of weight loss. But again, we shouldn't compare to bariatric surgery. It's technically lesser of an intervention. So weight losses have been kind of in the 9 to 17% excess weight loss range. But what about metabolic profile? You saw that large intensive medical therapy study, 175 minutes of exercise, diet modification, lifestyle change. At 10 years, there was 0.22% change in A1C. So at 1 year with the endo barrier, just lining the duodenum, you have A1C changes of anywhere from 1.1 to 2.4. And this is with only modest weight loss we talked about. So there is some interesting mechanistic issue here, some hormonal changes that raises some questions. Again, these are smaller studies, although some of them are technically, 2 or 3 of them are randomized controlled trials. But the trial got stopped early in the U.S. This was a U.S. trial, sorry, because of a liver abscess rate. Initially, it was 0.126%, which is quite low. But subsequently, several more cases occurred, and up to 0.9% in 3,000 patients. So that's still not a high degree, but enough to stop the trial by the FDA. There's a balloon. We're part of this trial. We've actively currently we've enrolled patients now. We're following them. This is so there are. I'll first show these balloons. These have been FDA approved this fall. Now they've been around some of them, like the Orbera, has been around in Europe for years, but it just got FDA approved a few months ago here. And this is a dumbbell-shaped balloon. These are placed endoscopically. So these are placed endoscopically and then removed typically 6 months later or so. This is a pill which is swallowed. It's the size of a large pill. And fluoroscopically, we confirmed that it's not in the stomach. It's in the stomach and not in the esophagus. Then we inflate it. And that can, but removal is endoscopic. So some reduction in cost, but no. And then there's a newer one which may be able to be swallowed as a pill, and in 6 to 8 weeks may just disintegrate and disappear the foam from an absorbable surface. So these are interesting in the sense that they're not going to be able to be compared to bariatric surgery in weight loss. But is there a role for, especially some of the cardiovascular high-risk patients? They're not going to make someone with a BMI 50 come down to 35, but if your BMI is 40, 41, and you may need to come down to 35 to get a heart transplant or have better performance on your LVAD, or maybe avoid an LVAD maybe that 20-pound weight loss may make a difference. Maybe they're really motivated. They can do a good lifestyle diet change, and with the help of this, can there be some options there? They do open up, but right now the issue is they're not going to be covered by insurance for the foreseeable future, at least. So, are the cash pay options that various hospitals come up with for the 6 months to year that they undergo this program? Is it going to be in the $7,500 type $8,000 range? Probably, but depending on how motivated the patients are, although many people wouldn't think twice about spending that for a car, but I think to qualify for a heart transplant list or something, or improve your health, you may want to consider. But the concern with these is what happens if you're doing it for a specific goal, like I said, qualification for certain surgery, improvement in health for a certain time period because you need to get a knee joint surgery or something. But what typically we think will happen 6 months later when you remove these, or a year later, is they will slowly reaccumulate weight. So it is, we think, temporary. And how does this all affect the heart? these weight losses, there are various small series of studies with different cardiomyopathies and ischemic, non-ischemic, that do show, a number of them will show improvement in their New York Heart Classification as well as their ejection fractions. Not everyone, but a fair amount just by when they lose a large amount of weight. Whether that gives them longevity or not, I don't know. But there are papers like these that show decrease in CHF admissions, improvement in LV ejection fraction after surgery from 21% to 35%, with the reduction in BMIs, et cetera. So these are some sort of a potpourri of weight loss things and mechanisms that I just put it out there, but I'd be happy to take any questions.
Hi, I've read some studies and heard about research that has found that some of the patients, there's a higher risk for alcoholism and addictive type behaviors developing post the surgery, specifically the RNY gastric bypass procedure. Are you guys finding that here as well?
So these are all, they're true to the extent that it's not a high incidence. It's a higher than their baseline, meaning if they were alcoholic, then they were dry, then they had surgery, they may have a higher recidivism rate. Again, these are usually, we think, temporary after the initial massive weight loss, and that to a certain extent that may affect there. And a lot of these patients, some people take up smoking, because not a lot of them, but a number of them will use food as a comfort, as a addiction, or so almost what you call it. So that does get sometimes replaced with other. And alcohol can be tricky, that because it goes directly into the small intestine, it gets absorbed quicker. It's like drinking on an empty stomach as opposed to a full stomach. They can get drunk quicker, so they can get that high maybe easier. But it's not a high. Hundreds of thousands, around 200,000 bariatric surgeries are done every year in the U.S., and it's not like everyone's becoming alcoholic or anything by any means. But it is higher than baseline. Just like that suicide takes a bump, alcoholism takes a little bump as well.
Yeah, a very, very nice summary with a focus on cardiovascular disease. I want to ask this question with the advanced heart failure patient in mind in the obesity paradox. Given that the overweight and obese patient with heart failure have a lower mortality rate, does that cause any pause when you consider putting in a balloon, doing a sleeve, or a bypass on these individuals?
It does on the surface. That's why, to be honest, we don't fully know yet. But my feeling is that most of those graphs that you see in the obesity paradox, lowest mortality is in the overweight and the BMI 30 to 35 range, not the 45, 50 range. So what we're basically doing is bringing the BMIs of 45 to 50s down to the BMI of 35 to 30. So we're actually probably bringing them in their optimal range. We're not bringing them down to BMI 20, 21, which would be, I think, detrimental, because that's what most of the data shows. But most of the data, both in critical care and in heart failure, shows that sweet spot seems to be slight. Maybe for those of us that are slightly overweight or plump, that's the best. When you're older, that's the way to go. There are various theories behind there. Is it that the thinner people that have those diseases, they have other issues going on metabolically or inflammatory-wise that are more dangerous? Is it the cardiac cachexia, that those that are thin, that they don't have reserve? We don't know, but it's probably all of those little factors. But I think the distinction here is that we're not bringing them down. We're actually bringing them down to the sweet spot, because many of those population-based heart failures show that it's not the BMI of 50s that have higher longevity. It's the 35, 30 or so.
Nabil, thank you for a great talk. I have about a dozen questions, but I'll limit it to two in the interest of time. One is, you mentioned the ileal transit time as a big factor in weight loss. And so, first of all, what is the normal iliac transit time, and does the sleeve gastrectomy affect that, or only the Roux-en-Y? And then the second question is, I have a lot of patients that are very resistant to surgery because they have a friend or a loved one that went through bariatric surgery and had a lot of side effects, nausea, et cetera. And what do I tell them about the incidence of those side effects and how to manage them and what to expect?
Sure, those are both very good questions. As far as the ileal transit time goes, so depending on the size of the meal and degree of motility, within 45 minutes to an hour, you can have food normal. I'm not talking about post-bariatric surgery in the sort of mid-ileum and beyond. And that's what works with that ileal break, where you kind of, if you're eating slower, or that 45 minutes, hour after a meal, you feel fairly okay. I'm really full now. But post-bypass, that can be in less than 20 minutes, if not 10 minutes sometimes. For sleeve gastrectomy, there haven't been any necessarily studies about it, but gastric emptying in many patients is quicker because it just kind of zooms through that little tube. So the assumption is that, yes, with quicker delivery to the duodenum and jejunum, likely there's quicker delivery to the ileum as well. Not as fast as the bypass, but probably some as well. Right. So the nausea, that's a very good, and so that's a two-part question. One is, so bariatric surgery has evolved a lot from what it was, both in terms of operations. So the operations that I showed, the vertical banded gastroplasty in around Texas, there used to be a surgeon here called Dr. Molina. He did 10,000 bariatric surgeries in this area and put all these little tight bands around everyone that are always having nausea, vomiting, which we're taking out now. So the types of surgeries have changed. Two, even within those surgeries, there is nausea, vomiting. Around 30% or so of bypass patients and 50% of sleeve patients for the first 3 to 4 weeks will require anti-nausea medication to some degree. But the other way it has evolved is the comprehensive nature of the program. So if you have smaller programs, sometimes what I call the strip mall bariatric programs, the problem with that is not necessarily that the surgeons aren't as skillful or as good, but the problem is if the program's into the sort of the high volume private practice model of just burning the numbers, and if anyone calls back with any issues, they're like, whatever, just talk to my nurse, and them not getting callbacks. And most of the time, especially several months out, if the bariatric patient is nausea, vomiting, something's wrong. There's a stenosis, something's not being addressed, or maybe simple diet education, the speed of eating and what you're eating. Are they getting dumping syndrome because they're eating the wrong things? They don't have a good pre-op education, they don't have a good post-op education, and they don't have good post-op follow-up. So those are big key things about how to educate someone, because a lot of people have trouble with beef after a gastric bypass, like steak and stuff. They do fine with chicken and turkey and everything, or they have to have a tender beef or so. But if they keep on trying that and keep on nausea, vomiting, and they're not aware, and no one tells them. And so now, we see our patients 1 week, 1 month, as surgeons, not just 1 month, 3 months, 6 months, 9 months, 12 months, 15, 18, 2 years, and then yearly thereafter, to help them with these type of things. Oh, sorry.
If I may speak, personally and professionally, I am a patient who had gastric bypass, and I lost 120 pounds. Just to answer your question, maybe I can help, and maybe I can help with your question. Like he said, pre-op education is the key. Before I had the surgery, I had to go through 6 months of pre-op education, a lot of diet classes, a lot of learning how to drink, what to drink, when to drink. And I'm 4 years out, and to this day still, just personally, depending on what I eat and how much I eat, the nausea is still there. Alcohol. To crack a joke, yeah, I'm a real cheap date because it doesn't take much. So to answer your question is very easy. But I will say this, if you are already addicted, just like obesity, a lot of times obesity comes with depression because they're using the food for comfort. So you have to relearn. It's not it's more of for me it was a mental thing because of course I couldn't go to a restaurant and say, yeah, let me get the 16 ounce anymore. You know, and it was difficult even after the surgery, even after the teaching. It's still hard to this day when I go to a get together or a function. And I mean, I've gotten a lot better with it, but I can't, knowing that I can't eat what I used to eat or how I used to eat. And even to this day, there are certain foods, and I can tell personally when something has too much fat, too much sugar, too much alcohol. You know, it physically my body will let me know. Just like now, I ate a half of that scone, and I can feel my heart racing. I'm doing about 130 right now. I'm waiting on it to calm down. But these are the type of things that your patients will have to deal with, and I'm a nurse, by the way. So these are the things that your patients will have to deal with as time goes on. And like I said, I'm 3 years out. And so as a person, you feel like, oh, I'm okay. I'm gonna get, you know, the buttered croissant, but it's gonna make you sick. So, you know, these are the things that and I did have to have the anti-nausea medicine about 3 months out. And I remember my surgeon had me on a clear liquid diet for about 3 weeks after and 3 weeks before. And this was around Thanksgiving, so it was so difficult for me, you know. So I had to relearn how to feed myself and diet and things like that. I don't know if that'll, you know, help answer your question, but just from a personal level, you know, and like I said, even with drinking, you know, these things, if they're not, the teaching has to retrain you mentally more so than physically. Because if you know how to do it mentally, the physical will follow. Can you see where I'm coming from?
Thank you. Thank you for sharing. Those are exactly straight what you heard. Very true.
One quick question. Has there been any long-term follow-up, say using DEXA to look at changes in regional body composition with respect to whether or not, in cases where people with large waist circumference, there's preferential loss from that region or not?
For visceral obesity you're talking about? I'm not aware any. I don't know if Dr. Hamilton, you're aware of.
There have been some studies. There is a central visceral loss. There's also significant body mass loss, too.
Mm-hmm. Yes, sir. Early on, you know, they're losing weight at sometimes in the first month at a pound a day or 20, 25.
By DEXA or some other more quantitative method?
No, I don't. There might be a few small series, but nothing longer term.
In the area of, or historically, nobody paid much attention to gut bacteria in the era of Billroth 1 and Billroth 2s, except for the blind loop syndrome. Is anybody currently paying any attention to the change in gut bacteria with some of these surgeries and see what effect that has on the weight loss and weight gain? Is my first question. My other observation is, as a non-surgeon, retired individual, internist, I think the secret to all of this is you're exchanging one set of problems for a different set of problems.
That good point. For the first part, as far as the gut microbiome, I think people are just starting to look at it more and more, and that is probably I put all those axes, enteroinsular and enteroencephalic, gut hormones to brain, but I think gut microbiome comes in there too. There's a surgeon in University of Chicago called John Alverdi who's doing a lot of research. He has a lab, NIH grants, etc. at gut microbiome, not just specific to obesity, but any GI tract complications, post-surgical issues, etc. So I think people are starting to realize more to look at gut microbiome. As far as, yes, you are right, you are exchanging some degree of problems from another, but the question is, you know, what's the sweet spot? The NIH criteria of BMI of 35 with comorbidities or 40 without. Is that the sweet spot? Is 45 the sweet spot? 50 the sweet spot? Where if you don't have this, your 5-year mortality is the same as colon cancer, especially if you have certain degree of heart disease and metabolic syndrome and cancer deaths. So yes, you are extending, but the problems that we discuss in terms of whether it's spike in suicide, whether it's alcoholism, whether it's excess skin that comes, these are all true problems that are there and they have to be factored in. But when you look at large overall health, for a large majority of people, there is a shift towards better health.
Thank you. Thanks.
All right. Thanks.